Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host, and we are coming to you from EBPOM live from London 2020. Now, it's day 2 here at EBPOM, and because this is a virtual event, I unfortunately am not in London, but I still can join. I'm in Louisville, just like many of you. So, it's been a great conference so far. We've heard from world authorities in perioperative medicine, and we have 2 more days of it. So a lot to look forward to. Streaming everything for 24/7. So we are an EBPOM connection to the world. Now, stay tuned for some amazing entertainment and our very first ever Pockapalooza. And I know you're probably asking yourself, what is a Pockapalooza? Well, to tell us a little bit more about it, our editor-in-chief, Monty Mythen, joining us from London, England. Monty, hello.
Hey, Desiree.
Well, it's beautiful and sunny there, Monty. Is that accurate?
It's the power of green screen. So, I mean, the truth at the moment is a little uglier.
Yeah,
you know where our studios are in West London, tucked underneath the elevated section of the M4. If we look out the window, it looks a bit like being under the L in Chicago or something like that. It's if you watch the live stream, the chatty stage out through the windows, people can see roughly where we are.
Yeah, well, usually EBPOM has some pretty amazing weather that week, so maybe you'll see some better dates as things progress. Well, Monty, how are things been going with the meeting?
I'd just say brilliant. I mean, I wouldn't. I think we've set you up a little spy cam, so you can see the truth off the stages, and it's pretty stressful. I think I'd take a day on ICU as being less stressful, even in COVID-19. But
I've seen you with roller skates on, going between the different stages, and
you've got an amazing team.
Yeah.
So you take clinicians combined with experts in their field with regards to broadcast and put them together. I think they can get pretty much anything done.
It's super cool. It is. Yeah. Well, Monty, I know everyone's wondering what a Pockapalooza is. So
I don't know.
It's of ours.
Yeah.
Tell us a little bit more about it.
Well, we're talking about the fact that, as you want to sort of globalize and socialize perioperative care in a big discussion and make it a little bit less stuffy. I mean, we do want to talk about the clever stuff, but we also want to talk about the practical elements of the before, during, and after major surgery, but also make it a global thing. And we were thinking of a term, and the perioperative care rather than medicine bit came relatively easily. And then I was a bit obsessed with this palooza word, which doesn't really translate that readily in the UK and possibly through a lot of the rest of the world. But in the USA, the Palooza, I think, is known to many people. Yeah. And as I said, I'd been to a data palooza in Washington. So I thought, well, let's have a Pockapalooza, because at least it gives us something to talk about. So it's an extravagant event, including some great entertainment. So I know you've seen the T-shirt. Yes. I know you've seen the poster now.
Yes.
For wrapped around the exciting scientific discussions and clinical discussions we have, for example, cooking from your garden and a yoga session and live bands. So
that's right. It's a great mix. Yeah, it's awesome. I loving the yoga. I've actually been doing a little bit during the I have a little bit more free time than you guys do. And it's been going really well. I'm super excited for the Pockapalooza, though. 24 hours around the world, Cape Town, London, Chicago, LA, Hong Kong, Sydney, and wrapping back up in Cape Town, and all for a very good cause, Monty.
Yes, starting tomorrow morning at 8 a.m. British summertime. You'll all have to work that out yourself. We're actually putting a set of global clocks now up on our communications because we can't keep track. Yeah. But we know it's 8 o'clock somewhere, and it's 8 p.m. somewhere too, depending on what you want to do. But we're raising money for the African Perioperative Research Group. Yeah. You'll find some links in our expo, and we'll send out some extra links to it. When you see that cesarean section is one of the commonest surgical procedures performed in Africa, and sadly, ladies are 50 times more likely to die from cesarean section than they are in West London, for example. So really important And that's tomorrow morning we'll start our interviews with the team, with the leadership in South Africa, and finish it there as well. So hopefully we can raise some good money for them.
Yeah, great cause, a wonderful mission. And I just ask, please, everyone, open your hearts and open your wallets and help them out. All the money goes to that very important cause that Monty was talking about. Well, Monty, we have some great conversations, just as we would be doing as live if we were in the conference exhibition area at our Top Med Talk booth. Everybody knows Top Med Talk has these amazing convos with, world authorities in perioperative medicine. And today we're doing the same thing, just virtually. We are going to be chatting about some novel patient monitoring technology that we can use during anesthesia and sedation. And it's my pleasure to introduce our guest, Dr. Frank Overdyk, professor of anesthesiology from Charleston, South Carolina, to discuss this. Hello. I guess I should have said Professor Overdyk, right?
Frank works fine.
Great.
Hi, Desiree. Hi, Monty.
Hi, Frank. Great to meet you.
Frank, for our guest, can you give us a little bit more about your background? Obviously, you don't have a very strong Southern accent, so I don't think you're technically from Charleston, but that's just a guess.
Right. Correct. That's a good guess. I can talk like a North Londoner because I went to high school in England. But
whereabouts, Frank? Where did you go?
I actually lived in Welling Garden City, so right a little up the road.
The deep suburbs.
I'm an anesthesiologist. Been a professor for a long time. My academic interest has always been opioids and their effects on ventilation, respiration. And about 20 years ago, I came across some cases of opioid toxicity in the hospital. Now, everyone is aware of the opioid crisis outside the hospital, tragic opioid crisis, but we've had an opioid crisis in hospitals for a long time. And we have a lot of patients on wards who have had an unfortunate adverse event, as we call them, with opioids and have respiratory arrests and such. So I started spending a lot of my academic time and my passion is patient safety regarding to opioids in the hospital. And I've been involved in monitoring projects for doing better monitoring on patients on the wards, specifically surveillance monitoring. We still have about 300,000 cardiac arrests in the US in hospitals every year, half of which happen on the ward, which is supposedly our low acuity setting, right? This is where we have our stable patients. So how do we have a cardiopulmonary arrest? 3/4 of those patients die, by the way, happen in those settings. They're not all, of course, there's a lot of reasons for them, but certainly opioids and sedatives and the management of those are a important contributor to that. Along the same lines, in the OR, I'm always very interested in opioids. I trained at a place that was very opioid-centric up in Boston. And we always have dosed our opioids somewhat subjectively. It's our experience. It's some PK/PD. And I came across this company, Mythen, from Israel, which has come up with an analgesia or a nociception monitor. In other words, a way to objectively monitor a patient's response to surgical stimuli, or any stimuli for that matter, and then allow us to maybe dose our opioids that way. And I now serve as a consultant medical director for them.
So if I may, Frank, so we've done a little bit on Top Med Talk about this before, so I think we might be a little bit ahead of the game in understanding this. We kind of got used to depth of anesthesia monitoring from something like the bispectral index or alternatives. And I kind of got the impression that what we're talking about here is sort of the similar idea, but with regards to how much your pain sensors are being stimulated. It's always going to be hard to say whether that translates through to the perception of pain. But am I right in that?
Correct. Absolutely. So in anesthesia, we basically have 3 components that we manage. We manage hypnosis and amnesia. That's one. And we manage analgesia, and we manage muscle relaxation. So the hypnosis and amnesia has been addressed with the depth of anesthesia monitors, the BIS monitor. Came in the 1990s. I, like most people at that time, was a little reluctant. I don't need this monitor, but since I've become a fan, because it really has a purpose. Trainer 4 muscle relaxation, that was introduced into the 70s. Now we have an instrument that can help us objectively measure the analgesic component. Pain and hypnosis are 2 separate components. They interact, but they're separate.
Yeah.
And you need to make sure you manage both of them. And so that's a great analogy. This is sort of would be the equivalent of that for the analgesia and the pain monitoring.
And depending on us as individuals and how we interact with the drugs, this idea that there's a dose that's going to make sure that I ain't hurting is just quite a long way away from the truth of the matter. Is that right?
It's so true.
Yeah.
So there's a 30-fold variability in pharmacokinetics and dynamics in opioid effect. If I give 10 milligrams of morphine to 100 patients, there will be a 30-fold variation. I always say there's just a starting dose of opioids. There's no safe dose.
Yeah.
So that titration always has to happen. That's where our skill comes in. But this monitor may help us be a little bit more objective with that, because the monitor allows us to see the patient's sympathetic nervous response to a noxious stimulus. Mm-hmm. And that's graded on a scale from 0 to 100.
And that's, if I may, for a last bit on this, Desiree, I mean, traditionally we've sort of given what we think is our best guess dose based on our sort of gestalt and a little bit of training, experience, knowledge. And then if the patient has something like a little bit of a tachycardia or a rise in pressure or something when something is done that might be hurting, we give a bit more to see if it goes away. I know that might sound very, very crude to people listening, but that's where we are at the moment, isn't it? I think
it's scary, but yes, we use surrogate measures for analgesia, and we use heart rate and blood pressure for the most part. But as everybody knows, there's many things that can make the heart rate and blood pressure go up or go down, things that are unrelated to noxious stimuli. So this monitor has some parameters that are specific to nociception to painful stimuli. Now, I keep saying the word nociception. It's a little different from pain because pain is a sensory and emotional experience. So in the truest sense of the definition, pain, you have to be conscious to say you have pain. And what is our gold standard for pain? It is the visual analog score, the numeric pain rating from 1 to 10. So pain is an awake condition, but nociception is actually when we're anesthetized and we're deeply anesthetized, we can't give a pain score. So that's the equivalent thereof. And our body lets us know what that score is by the value of these things that happen when we have pain. We vasoconstrict, we sweat, our pupils dilate, all these kind of signals. And the blood pressure and heart rate could go up or down, but those are non-specific.
Frank, one question I wanted to ask, I mean, as a CRNA myself and, practicing in the OR, one of the things is that I'm open to new monitoring technology, I'm open to new tech, I'm open to new ideas, but kind of need to understand the why, the why and how it works. So can you just kind of do a little bit deeper dive on that?
So Desiree, we've all, as good as we all are at what we do, we've all had cases where we give too much or we give too little. And that is the consequences of, we tend to err on the side of safety. And we've had this, what the BIS monitor told us and what some of the research since then on the triple lows has shown is that our outcomes maybe aren't so good because we kept patients too deep. Well, the same applies to opioids and analgesia. If we give too much opioids, we may have a patient who is slow waking up, slow breathing, and in the PACU you may have some airway obstruction as a result of opioids. So there's a downside to not getting that right. And on the flip side, if we under-analgese patients, the stress response, the stress hormones are bad for wound healing, they're bad for the patient, they're bad for patient satisfaction, but they're bad for all those things. So it's really good for us to get the analgesia equation right. And I think we all have developed our practice and we're probably pretty good at it, but there are some situations in which that's very difficult. For instance, on the weekend at 3 a.m., I might get a brittle patient in their 90s for a broken hip and who cannot be positioned for a regional anesthetic, and I might have to use a general anesthetic. What greater things than a pain monitor as well as a BIS monitor to allow me to titrate that so I can get that just right?
Yeah, I mean, there's nothing worse. I think as someone every day, I want my patients to come out looking great. There's nothing worse than to have someone that you have just missed the mark on, and either they truly are severely oversedated Or I think almost worse. Yeah, I mean, that has a lot worse implications, I think, but also coming out and you think you've hit the mark and that patient is screaming, writhing, coming out of bed. And I think any tools to help us, do that. Right. And especially, I will tell you, working in Kentucky, we have a lot of chronic pain patients. We have a lot of patients that are on, heavy narcotic users already. And that's changed just a little bit probably in the last couple of years, but I still say we're dealing with that a lot. It's so hard on those patients. How does this technology kind of address that?
So certainly that's one of the patient populations where this is extremely interesting. That's the opposite of the example I just gave. Opioid tolerant patients they become unaffected. Their dose response curve moves all the way to the left. So you have to give much, much larger doses. But we quickly get to doses that we're quite uncomfortable with. And this monitor, but these patients still have sympathetic nervous system responses to noxious stimuli. So yes, they do vasoconstrict. And we'll talk about some of the input signals that this machine uses and the algorithms that it uses. But those patients who have very high tolerances will display more of that physiologic response to a surgical stimulation or to an intubation than your typical patient.
Yeah, and in the instance of like hyperalgesia, too, where it seems like they're just more sensitive.
Right, and the nice thing about this monitor is it also has takes a baseline reading, so it sort of auto-calibrates, which is really important. We know that's important for any kind of physiologic metric that we take.
Right.
Now, Frank, we were going to have at our meeting in London that went from being physical to virtual, we were going to have a big full session about the development of nociceptive monitoring and do a much deeper dive on all of this, because we've sort of been aware of it for quite a long time, but we've been waiting. It's a bit like the depth of anesthesia monitoring story. We've been waiting, it seems like decades, for something to come along. Where is the monitor in the regulatory approval cycle at the moment?
So, you're lucky enough in Europe to be able to use it. And you can use it inside the OR, outside the OR, and in the ICUs, which is really important during this crisis. In America, we are applying for the FDA for a 510K. But because there is no predicate, which is the easiest way to do it, we have to jump through a few more hoops.
Using the depth of anesthesia monitoring example, because there was no predicate, we had to sort of pragmatically as a community say enough already, because we're going to have to sort of learn by doing as well, and we'll never...
Correct.
We'll never, although they got there eventually with the large pragmatic trials funded by bodies outside of just industry, because they're massive trials eventually.
Right.
Hopefully we can get that
right. So awareness was a big thing, was a big push for depth of anesthesia, preventing awareness, because that's a tragic outcome. Same thing for pain. But yes, we need to, what we have the advantage now with our regulatory path is obviously that we have this great body of clinical experience of established installed base that's giving us data all the time. Yeah. And can show us that there's very little risk, relative little risk to a lot of benefit to this, both in the OR and outside.
And from the point of view of the business case side of it, which is once we say this is really cool, we'd like to do this, we're comfortable with this, then someone comes along and says, whoa, hang on a second, show me the money.
Sure. You always have to have the health economic benefits, the return on those kind of things. I think we have an issue. We've identified that a lot of chronic pain use, opioid use, starts with surgical procedures. Yeah. That is the gateway, so to speak. We've had surgeons who have traditionally, by practice, given large prescriptions of opioids, going, well, I don't want to get cold at 3 a.m. Why don't you take all these? We now know that our surgical, how we treat the opioid, how we use opioids in the OR has an implication on the patient after they get discharged. So I think there's a real case to be made for that both the societal and the health economic needs can improve if we do a better job managing opioids in the OR, in the PACU, and hopefully on the ward as well.
If I'll let Desiree take over to wrap here in a second, because I know we're under a bit of time pressure. If I wanted to learn more about the technology right now, Frank? Is there a place I can go and look at it online and see it? And
yes, actually,
yeah.
the Medicines has a very nice couple of white papers on the algorithm itself, the technology. If you're into deep learning and machine learning, there's something called the random forest. Not as beautiful as the black forest, but it's the algorithms where this relationship between the sympathetic response and this value between zero, the null index, was established.
Great. Yeah, that's great. Because I was just going to say, I know in the interest of time, we may not be able to really get into every little point that it's measuring. But I think if we have something we can signpost people to, that would be great.
Yeah.
Yeah, great. Well, Frank, in wrapping up here, my biggest question is, where do you see the future of this technology? How do you really see it playing a role in everyday practice, for anesthesia?
Right. Well, I think we have to establish the benefit of this technology. I think in the OR is the first place. But then the golden application for me is on the wards, right? How do we get a subjective measure of a patient's pain? How do we know whether someone is malingering, not malingering, or someone is overstating their pain, understating their pain? And then we get into these issues where we find someone dead in bed because the nurse didn't know. They said they had 9 out of 10 pain. They gave him more morphine. It's really in the awake and in the sedated, in the ICU being a great other example. A lot of delirium, some PTSD after prolonged mechanical ventilation. Some of it's related to inadequate pain and sedation. Those two come together. That would be a great monitor to help do that.
Interesting. And do some of those white papers address utilizing this on sedated and awake patients?
Well, that body of evidence is now getting created. Of course, the COVID, unfortunately, is precipitating that. There isn't a whole lot of hard data on that at this point, but it's growing every day.
Yeah, something definitely to look forward to for sure. Well, Frank, thank you so much for taking the time out to chat with us. This has been a great conversation. Hopefully we can catch up with you later on in the year to talk a little bit more about it and see where you guys are in the process and hopefully move things along during the COVID crisis as much as possible. But we do appreciate you sitting down with us or chatting virtually with us.
My pleasure. My pleasure. Nice to see everybody.
Hopefully we'll see you at one of our upcoming meetings, Frank. And next one's in Chicago. I'm not sure I'll be allowed to go, but maybe someone that...
You may not want to go, but yes, we'll see how that all works. I hope so. Nice to see you guys. And,
Thanks very much.
Yeah, thank you so much for joining us on Top Med Talk here at EBPOM London 2020, live from London.
Top Med Talk.
Please be sure to check out the Expo map for more information about Top Med Talk, about the Pocketpalooza, and of course about the APORT African Perioperative Research Group fundraising. So please, 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 again, like I said at the start, please open your hearts and open your wallets and give to this wonderful cause. And please be sure to stay tuned because throughout day 2, we're going to have more conversations at most of the breaks. At 10, we're going to be talking to Jim Down and panel about sedationists. I know, hot topic. And we're going to be talking about video laryngoscopy during the COVID crisis, as well as some different initiatives taken to help with remote monitoring. So lots of cool info today, and Pocketpalooza starts tomorrow. So thanks so much for listening. We'll see you again soon. Cheers. Bye.